Hello to everybody. Now we have a thematic debate, and the title of the thematic debate is Should low-risk patients with polycythemia vera or myelofibrosis be treated? I am Francesco Passamonti, and I serve as a chair of this thematic debate. And together with me, we have two great contenders today. Professor Christen Andersen, who works as a senior physician and head of the MPN Center at the Rigshospitalet in Copenhagen. And Christen is an MPN expert and also as the chair of the Nordic MPN study group. And I think that Christen follows the long Scandinavian tradition for preemptive treatment in patients with myeloproliferative neoplasm. As for this reason, he has been asked to take the yes stand position for today. And then we have Professor Claire Harrison, who works as a consultant at the Kaiser St. Thomas Hospital in London. And I have to say that Claire has influenced the major advances in MPN field from the discovery of the mutations, so the driver mutation, traditional mutations in MPNs, to the design of global clinical trials. And she also creates a patient charity, the MPN Voice, and also participated to the development of other charities such as the Blood Cancer UK or the MPN Research Foundation. And she has been asked to take the no stand for the today debate. This is just an introduction, so who is at low risk in PV? We have different possibilities to stratify this patient, but I think today that we have to consider the conventional risk stratification that include age more than 60 and prior risk of thrombosis as a risk factor for thrombosis. We can use some other mutations such as SRSF2, IDH2 that can predict OS in some study. IDH2 ranks 1 who can predict leukemia-free survival, and U2AF1 that can predict MF-free survival. And then we have also the recent eLearning recommendation that provides some recommendation about the indication for the use of cytoreduction, such as poor tolerance to phlebotomy, symptomatic progressive splenomegaly, increased leukocytosis, increased thrombocytosis, a high need of phlebotomy, and also an excess of symptomatology, and so on. The second point is myelofibrosis, who is at low risk in MF. And for primary myelofibrosis, we have to consider the IPSS, the IPSS that used very simple clinical parameters. The mid-70 that added to these parameters also bone marrow fibrosis, the presence of driver mutation, and also the presence and the number of additional mutations that define the high molecular risk. For post-PV and post-AT myelofibrosis, we have to consider the MySEC-PM that combine clinical parameters to the driver mutations. So these are more or less the reason why we have to discuss about this point. So this point is quite relevant, and we have to consider these categories. So now it is time for Christen. Can you present the key and facilitate the discussion? Thank you.
Yes, I certainly can. Thank you, Francisco. And I hope you can all hear me. I've switched to my AirPods, but yes, thank you. Okay, so this is a male patient of mine, a 40-year-old man who was referred to us with a high hemoglobin count of 13.9 micromolars at 22.4 grams per deciliter. He had normal leukocyte and platelet counts when we met him. And blood sampling was actually performed as part of a health checkup as GP in an apparently asymptomatic patient. But when we questioned him in the outpatient clinic, he was suffering from oncogenic pruritus in a mild to moderate degree. But besides that, he was doing just fine. He had no comorbidities, no hypertension, no hypercholesterolemia, which we obviously check at baseline as well. Was a non-smoker. He didn't really drink. He was very physically active. And by the way, he was a physician, so he was a colleague as well. EPO levels were low, no splenomegaly at ultrasound. We always perform a bone marrow examinations up front, typical for PV, no iron stores as expected, and importantly, no fibrosis. We performed a JAK2 mutational testing with a very little frequency of 58%, and he wasn't assessed for any other non-driver mutations at that time. Karyotypically normal, and we concluded this is indeed, as you just beautifully showed, Francisco, a true low-risk PV patient. Started aspirin, phlebotomies, and then what about cytoreduction?
Please, Christen, you have now to convince us to start a treatment for these patients.
Okay, so let's see. Obviously this patient starts phlebotomies and aspirin. We have some data of that. But the real interesting question here is, should we try to implement some kind of cytoreduction in this patient? And it should be considered, as we say, is nationally and in the Nordic European setting. Yes, it could be with a poor tolerance, high frequency of phlebotomies. Well, we did not know at the time. We just met him with a symptomatic progressive splenomegaly. He had none other evidence of disease progression, progressive leukocytosis, as you all know, and several risk factors, but he didn't really have any of those. But also, if there's a personal motivation for treatment of PV, and we do have a certain drug that could potentially influence both his long-term and short-term risks, maybe that was worth trying, even though he did not possess any of these major risk factors. So actually, he did start cytoreductive treatment. He started in 2014 with Introma, the unpegylated form of interferon, because we know that in some patients we have long-standing molecular remissions. We have pretty sound data of that accumulating nowadays, and we even have evidence of histological remissions as well. And when he started, he responded well. And by 2015, 1.5 years after he started, his variable allele frequency was below 10%. And actually in 2017, he stopped interferon again because he had a JAK2 mutant allele burden below 1%. Today, 2022, I speak with him every 6 months. He has normal peripheral blood counts. He's asymptomatic. He's still taking aspirin. I performed an NGS during his course just to make sure that his allele frequencies weren't falling due to competing clones, but he was really doing well. And this is a nice example, I think, where we show that we have the evidence that we can avoid the first occurrence or recurrence of thrombotic complications in such a patient. He remains a very good quality of life. He's asymptomatic. He has no constitutional symptoms. And I think we've minimized his risk of secondary acute leukemia and post-PV myelofibrosis with the data we have today. So I would definitely argue that such a patient as him, when he has been thoroughly briefed and we've discussed the pros and cons of preemptive treatment with interferon in this case, is definitely the way to go. So I would argue that, and I'm pretty sure that if the aftercare has tackled me, that we could discuss maybe some of the sound data that you do have to support this notion.
Please, Claire.
Thank you.
The question of Claire is no. We can wait. Yeah.
Yes, well, of course, the option is we're really discussing whether this patient should have an additional drug to control blood counts. Of course, the patient should have venesection and aspirin. So I just want to make sure that nobody voted yes, thinking that this was just a vote about aspirin and venesection. The problem we have is that we're still lacking prospective data. And I would agree that on an individual patient basis, of course, Christen's patient is a physician and you can discuss the pros and cons of therapy with a physician. But at the present time, we're not clear that preemptive treatment with interferon in a patient such as this, whose parameters I plugged into the personalised prognostic score, one that you mentioned, Francesco, earlier, his median event-free survival would be 25 years. So I think this patient does need active management, but my preference would be to offer the option of interferon, but to gently discourage until such time as he develops features of higher risk disease. And mainly that argument is on the basis of the lack of clear evidence at the present time for reduction of the allele burden. And although this patient did very well, that only occurs in 20 to 30% of patients. We're not talking about a drug which is We're not arguing not to treat CML with a tyrosine kinase inhibitor here. We're discussing a drug which is much less potently active. And there are subtle side effects of interferon. So I think it's really important to take a careful approach with the patient, to be very clear, and to consider treating not just a patient who is low risk, but a patient when the emergence of other factors occur. And that's why the ELN guidelines and other guidelines, including the British guidelines, reflect that we should just be treating patients who have a high burden of venesection, a high symptom burden, or a progressive leukocytosis. So my position for this patient would be not to implement treatment as yet, but that we in the field should continue to gather information and evidence before we subject a patient to treatment.
Okay, may I comment, Francesco?
No, we have to comment after, so we have to proceed with case number 2. So what I think is quite important that we have collected your opinion, and so we can proceed with the case on a patient with myelofibrosis. Please, Claire, can you comment?
Okay. So for this case, I've chosen a patient that's slightly different. So this is a much younger patient. The patient is 24, found to have thrombocytosis on a routine blood test. Patient is asymptomatic. And to first glance, this patient might seem to be a patient with ET. The white blood cell count is at the upper end of normal, the hemoglobin is normal, and the platelet count is clearly elevated. However, the blood film shows some teardrop poikilocytes, no blasts, and the LDH is double the upper limit of normal. So this case illustrates the importance of really carefully evaluating patients with this clinical picture. There was splenomegaly, 14 centimeters on an ultrasound scan, and a calreticulin mutation type 1 was detected with a VAF of 23%. A bone marrow biopsy, which I would always perform in a patient with a thrombocytosis and a positive CALR mutation, was consistent with primary myelofibrosis, but we already had a hint of that from the perspective of the LDH and the blood film. We went ahead and did an extended myeloid gene panel in view of the bone marrow findings, and this, alongside of a SNP array panel, was normal. So the conclusion for this patient is that she has primary myelofibrosis, which is low risk according to the appropriate scores, IPS, GIPS, DIPS, and indeed the MIPS 70 version 2, and also according to the Grinfield personal predictor. So for many of these scores, this patient would have a median survival not reached.
Thank you, Claire. How many scores have we did on myelofibrosis?
Sure. So just to talk about this patient then, she had support from a young person's team, and for sure, of a patient at this age, we had a discussion that at some point she will need a treatment. In particular, we would talk about transplantation and testing siblings. This patient would be reviewed every 4 to 6 months with a blood count, a film, LDH, check of symptoms, and an annual ultrasound scan. I'm not clear about the value of repeating the NGS panel. She's currently 5 years from diagnosis, well, not different from first presentation. The VAF of the CALR is unchanged, there's no new mutations, white count is stable, hemoglobin is static, platelet count is around 550. So we haven't treated this patient, and if I was to consider treatment options for her, there would really only be 2 at this stage. I mentioned transplant, just from the perspective of talking to the patient about it, but of course we would not consider that for this patient. So I think there are 2 options for treatment here. One is interferon, which we already had some discussion about for PV. The data for this agent with a patient who has a calreticulin mutation is less strong. Recent data in patients with ET presented by Dr. Mullally suggests that there's no appreciable change in the CALR mutation burden. There's a 20 to 30% risk of side effects. And the benefits for patients with primary myelofibrosis, for which we mainly have data from colleagues in France, is at best modest. For JAK inhibitors, I think this patient has no splenomegaly and no symptoms, and there's no current data for intervening early with JAK inhibitors. We tried to do a study with patients with high-risk mutations, and unfortunately, we were unable to accrue sufficient patients. So the main argument against treating now is what is the target and a lack of an effective agent. And I would say for a disease like myelofibrosis, this is an unsatisfactory position, but it is the position we find ourselves in.
Thank you, Claire. Christen, can you explicit your position?
Yes, thank you, Claire. Well, while I agree that the data make me less strong, I think that when we look at the prognosis for this patient in 20 years, according to the Greenfield calculator, she has a 70% chance of being alive. So this is a dire diagnosis, and this young woman could be in trouble. I think that you should start preemptive treatment. I think you have a pretty good data to support after a proper information to also start interfering on this patient. We know from CALR mutated ET patients that it decreased their allele burden in a proper proportion of patients with actually a very low discontinuation rate. And one thing we also know is that if we wait until a second mutation occurs, for instance, then the efficacy will be worse. So by waiting until her splenomegaly progresses, until this young woman becomes anemic, we immediately limits the additional therapeutic regimens we have. Once she's anemic, it's not a pleasant position to be in, because our agents for improving anemia in patients are not very good. So we can't wait until the splenomegaly becomes big. We can't wait until the second or third mutation occurs, because we hinder ourselves and we put this patient in a worse position. So I think with the silver data, the Virgia data, the collagen data, all the data we have on interferon in CALR mutated ET and also in PMF patients, actually low-risk patients, we know that treatment in a low-risk PMF patient just fares better with interferon if we wait until the intermediate risk or high risk. So this young woman only has things to lose. She can only win by starting interferon if we have informed probability. So I would definitely, with such a young patient, argue to start preemptive treatment.
That's really well your position. And I think that now we have time for a sort of debate among us, also receiving some Q question from the audience. So I have just one question for you. So we have a patient with PV.
Yeah.
Leukocytosis or the VAF of JAK2 is relevant in your decision or not?
You're asking me, Francesco, sorry.
So,
Let's hear your opinion first, Christen.
No, I don't want to. No. Yeah, of course, it's interesting, but it's only a part of it. So, high JAK2 mutant allele burdens are worrisome, because we know from the ET population that their allele burdens are lower. Once you have about 50% JAK2 mutant allele burden, that most often homozygous and tend to be PV patients, and things are spinning out of control. So the JAK2 allele burden, the leukocytosis, all of those aspects I see as indications for treatment with interferon, because we have more and more data supporting the incredible value of this drug in the long term. And I'm obviously referring to the low PV study, but especially also what we've just seen for the PV and the CON study with a 6-year follow-up. So hematological remissions are good, phlebotomy control is good, allelic burdens are very good, and event-free survival is superior. So I wouldn't just take one part of the equation out and say the VAF is important or the leukocytosis is important. I think in total, these patients should, if there are no contraindications, be treated. And so all the different trials we have, the PROPV and the NPDRC and low PV, are super interesting in the short-term run. But what we just saw from Abusilna, which really gives a story about what happens to these patients in the long term. And that's really the data we've been missing, the myelofibrosis-free survival, the overall survival. Well, I think it just goes to show that patients fare very good in the long term if they are on interferon. Both due to the myelofibrosis degree, much better, and actually with a very nice profile of side effects. Only 13%, max 20% discontinue the drug. So I think in regards to PD, we have pretty sound data.
Christen, sorry. If you are discussing about quality of life and side effect, the decision of a preemptive treatment is a drug such as interferon with a 20% of discontinuation due to side effect versus nothing. It is, of course, very well tolerated. So the decision to do just the bottom aspect. Claire, which is your position about leukocyte and VAF?
Well, I think the two are probably linked biologically, aren't they? Let's be honest. I think that leukocytosis, as that's going up, I suspect that my patient's VAF is going up. I think we don't really have a very clear threshold, so we don't help the community very much. And just thinking back to the patient that Christen presented, for sure I would have discussed a treatment with that patient, and as I mentioned, I would probably have discouraged. But I would have said to him, if your white cell count leukocytes are climbing, if they climb beyond, I think Professor Barbui's data suggests 11, but for myself it would be more towards 15 or so, or if the patient acquired a cardiovascular risk factor, then I would initiate treatment. I think we have to think about the natural history of these disorders and understand, the lovely data from Jyoti Nangalia and Dan Mullally, suggesting that patients may actually have these mutations at a low level for many years, many years, sometimes developing in utero. And I think we couldn't possibly be sitting here debating treating those patients with interferon. But if we had a better drug that was better tolerated, because there are many other issues around interferon, I know you're not talking about that now, that could be an issue. And I think if we had something we knew would change the scenario, then we wouldn't be looking, and expert recommendations wouldn't be around softer issues. I'm curious though whether we think we should actually switch our thresholds for treating to a certain variant allele frequency rather than a white cell count, because we know that's affected by many things. For example, other drugs, ethnicity can affect the leukocyte count.
I think that when we have to decide the preemptive treatment, we need to be very sure that in a patient with low risk, we are modifying the natural history of the disease, or we have a drug that is able to be really disease modifying. So the point is today, have we enough evidence for the literature to say that in general interferons can reduce the issues of epithelial, such as thrombosis, because thrombosis is the most important one. Then for testing myelofibrosis or AML event-free survival, we need the long follow-up that at the time we have not yet.
But we still should generate that data. I'm pleased to hear that you're saying, Francesco, that we have not yet got that data. We still need it. And I think the other thing to mention, what we know from the very nice Swedish cancer registry, and is quite intriguing, is that that many patients who develop AML, for example, which is the most devastating complication of these diseases, are often JAK negative. So we don't know the data about AML that occurs after interferon. Maybe it's less, but maybe we also have some biased data because we generally treat younger patients with interferon, so their risk is a bit lower.
So our statement must be around the ropeg interferon trial that compare ropeg versus And the follow-up is 5-year published and the 6-year presented at EHA just days ago. So that's a number we have to consider. Christen.
Yes. So, I just wanted, concerning the side effects, also just bear in mind that a substantial amount of the patients that we phlebotomize actually endure with a lot of side effects due to iron deficiency. And some of them are actually faring not very good. I completely agree with some of the side effects that may limit the use of interferon, especially fatigue, which is a common one. But just also remember what we had come to learn with the newer formulations of interferon. You remember the old unpegulated forms, so many side effects, and then we had Intron and Pegasus improved. And what we know now from ropic interferon, it's a very well tolerated drug. It's every second week for these patients. So I just want to mention the side effect aspect of things, especially in comparison with being untreated. Doesn't actually mean that you're asymptomatic. You could have quite severe side effects to your iron deficiency. And I think from the low PV study, those, we can see that the ferritin levels increase. We can see that the symptom burden decreases for these patients. That's interesting. And again, I just also want to emphasize, and I agree with both of you, obviously, that it's the long-term data that we need and that we are collecting right now. But for the 6-year follow-up in the CONT-PV study, end-free survival was much better. And that's after 6 years. And the American Silver paper, well, we can see that it's much better in regards to myelofibrosis-free survival and overall survival. So I really think that if I'm pretty sure that if we have this debate in a couple of years, then things will be different. We are getting the data that we have been in dire need of for the last decade, right? We are getting the data and it supports the preemptive treatment.
We have now to move to the second disease because you have to discuss about the second disease, and now we have just 15 minutes left. So the second disease is myelofibrosis, that of course is a completely different disease with a worsened survival at each risk category. So my first question for you is NGS to all low-risk patients, and we have also a question from the audience about SNP array. So NGS, SNP array, which is your position?
Well, maybe I'll start and then Christen, you follow, because I mean, these tools are more widely available now, and we can have a turnaround time of 2 weeks. So I could see maybe in 1 or 2 years, we might just be going straight to an NGS panel. In fact, we use a small panel for MPN diagnostics anyway. I think in a young patient, it's useful to know the mutational profile of the patient, and that an NGS panel is very helpful from that perspective. Just imagining if we found that this patient, for example, had an ASXL1 mutation or an EZH2 mutation, it would increase her risk parameter in some of those models, but it probably would not encourage me to use a treatment. I might monitor her more closely. And we just generally choose to do a SNP array because it's a little bit more sensitive, and you don't need to have mitoses to do that. So that's just local practice, actually. But I would do that, yes, in all my young patients. But of course, I was using it in this case to make the argument that this was a very low-risk patient. Christen, what do you do in Copenhagen?
Yes, we've had that talk for many years internally, and we do it up front, and we do it for everybody. And for the younger patients, obviously, because we need to know what is going on, and we need to know if there are competing clones, and we need to know if certain variant allele frequency fall or a decline. Is that due to some kind of battle going on the battlefield? So we do it up front, and I think it's also very important to gather that data, because the more data that we do gather this way, the better we will be predicting down the line. So NGS in all low-risk MF patients, yes.
Okay, thank you for your comments. So I think that as we did in PV, also in MF, the big question is we have now two categories of drug. One is the JAK1/2 inhibition that is represented by ruxolitinib and fedratinib, and the second are interferons. So can we modify the natural history of the disease, myelofibrosis, starting JAK inhibition or interferon earlier? That's a question. I think that this is the most important point to decide about our patient, because of course myelofibrosis is not PV, so it's much hard disease, much complicated. Claire?
So, I deliberately chose a patient with a CALR mutation because I think really JAK2 positive diseases on a spectrum. I would still argue, though, even with a JAK2 positive patient, that the PROUD PV data that patient population is a bit skewed. It's not correct to say this is a well-tolerated treatment completely. Patients are highly selected, and Dick Silver's data showing perhaps less MF transformation. Those MF patients, those patients that receive interferon are younger and their risks are less. So I think there is not sufficient data for disease modification with in low-risk patients or even high-risk patients with interferon. I think there may be some data with ruxolitinib, but only as applied to patients who've got a much bigger burden of disease, and the disease modification that we might see and improvement in survival there may really be because we're turning off or dialing down at least a high degree of inflammation, etc. So I'm not sure that those same benefits would be seen in a younger, low-risk patient. I think we're really in a very unsatisfactory position as a field, and we need to take steps to drive this forward and to understand better how we can influence outcomes for our low-risk patients with MF. Maybe that the answer will come from allele burden reduction. It's interesting that, you presented some very nice data with navitoclax in combination with ruxolitinib, and for navitoclax with ruxolitinib in a second-line setting, if we see allele burden reduction or fibrosis grade reduction, we see improvement in survival. So if we could take a drug and show that in a robust way, then we could perhaps use that drug or those drugs earlier in the course of disease, but we're not in that position from my perspective. And it's a shame.
I think that this is a quite important point, and thank you for comment. The result presented at EHA, and you present a result on very nice result on the use of pelabresib plus ruxolitinib with alteration of a megakaryocyte. And this is in the morphology, so the clustering. I think that these are biological aspects that are quite important, but of course you use this new combo in patients with intermediate 1, intermediate 2, and high risk, mainly intermediate 2 and high. So do you want to comment, Christen?
Yes, thank you. So I agree. It's very positive that we, for these higher risk patients, seem to obtain more and more therapeutic regimens nowadays. But again, it's unsatisfactory. And the thing is that the patient we discussed before, and the patient group that we're discussing today, the low-risk PMF patients, are not obviously the target of combinational therapies. And as I also agree with you, ruxolitinib doesn't really have its place here. But we do know that younger patients, the lower grade of myelofibrosis, and especially the low risk PMF patients, they respond better to interferon as well. So having letting your patient, quotation mark, deteriorate to a higher risk setting, it eliminates your possibility of disease modifying with interferon, and it really limits your possible therapeutic regimens for this patient. So waiting for a low-risk PMF patient, waiting for the additional mutation, as I mentioned, or waiting for the spleen to enlarge, or waiting for the patient to become anemic, it really only limits your choices and it puts the patients in a worse situation. I agree, we really need some, it could be nice with some prospective randomized studies here, and ROPEC would be very interested in the low-risk PMF setting. But I think that the SILVER data, which is pretty interesting data, it showed that the low-risk PV patients, they responded. The intermediate-risk patients, they did worse. And the non-responders, they had additional high-risk mutations. And why wait for that? Why wait for that to happen and then limit yourself in treating that patient? And I'm discussing the low risk, not the high risks.
Christen, I have a question from the audience just for you. So your treatment, your decision to treat a patient with ROPEC interferon is regardless of the presence of JAK2, CALR, and PN mutation, correct?
Correct. I can't treat it.
No comment. It's just yes or no, because we have no time to discuss it.
No, yes, I can't treat with ROPEC, and we don't have access to ROPEC interferon.
Okay. The second point is aspirin in low-risk MF to prevent thrombosis. Yes or no, Claire?
I would use aspirin, but I think the evidence for it in a CALR positive low-risk MF is slim. I'm more keen for JAK2 positive patients to have it, but I would give it to all of them.
Christen? Aspirin in low-risk MF, yes or no?
If the patient had a CALR, I would look at the other risk factors. It's so difficult to say because we don't have the data. To have additional cardiovascular risk factors, lifestyle factors, things like that, that would probably tip me to the choice.
But Christen, sorry, you're not sure about aspirin, but you're so sure about interferon.
I am, and I think the data I have to support that is very good. Just look at what we have seen in the last years. But if I can just elaborate a little bit on that, it's because we know that for the low risk ET patients with CALR mutations, we're probably not doing much good with aspirin, right? And the thing is, we don't have that data on the PMF. So if we had a patient who I've known for years and he had progressed from ET and was on aspirin, I would probably keep that patient on aspirin. And if the patient had additional risk factors, I would definitely do it. The thing is, we don't really know for de novo PMF patients. And what about when the platelet levels deteriorate? When do we stop clear? That's another thing. So when they have 75, it's super difficult. That's just what
I agree. And I was only having some fun and scoring a cheat point from you. But I mean, actually, the data suggests that myelofibrosis patients do have quite high risk of thrombosis, and that especially the ones that look a bit like ET.
Yeah, I agree, but we have to move. Sorry, this is a very nice discussion. Aspirin is quite important point because, as Claire said, the risk of thrombosis in primary myelofibrosis and secondary is 4 per 100 patient years, so it's quite high. But we have the problem, of course, of bleeding, thrombocytopenia, and so on. That is.
We don't really see that data split by mutation, do we, though? Because I sense that's probably driven by JAK2 positive patients.
Yeah.
That's interesting.
That is interesting. Yeah.